Assalamu alaikum. It's an honor to be here, and I would like to thank the committee to give me the pleasure to share my experience and talk about my therapy. It's a very long topic, and I don't know how I'm going to run through, but already Shabana and Stefano has basically explained everything, so I don't need to go into the details. So anyway, Theranostics is a combination of therapy and diagnosis. Put together, it becomes Theranostics. We are into the era of personalized medicine. Before, we used to treat these patients at random pace, so hit and trial method, but now we are very personalized with the ability to offer the right drug to the right patient for the right disease at the right time with the right dosage. So this is what yesterday we were talking about. This will save cost, like Lieutenant General talked about, and we will be able to save money. So new field of medicine which combines specific targeted therapy based on specific targeted diagnostic tests and a key focus on a patient-centered care. Provides a transition from conventional medicine to a contemporary personalized precision medicine approach. Molecular imaging is a visualization, characterization, and measurement of biological processes at the molecular and cellular level. Radioisotope will localize in the area of concern where it accumulates, thus minimizing side effects and improving the therapeutic ratio. What we need to do is we need to optimally patient selection, optimization of the therapeutic indication, and optimal patient follow-up reliable test. So we need to identify, do a diagnostic stress, identify the patients, select the patients, then you administer the therapeutic dose, the agent attaches to the target cell and starts killing the cells. So it's very personalized and targeted treatment. We have got different tracers, it's already been alluded to, but I'll talk what I'm practicing and I've been practicing. I've been dealing with MIBG, iodine 131, lutetium PSMA, lutetium dotatate, yttrium 90, radium 223. At present we don't do it, it's not available, and yttrium 90 for radiosynovectomy. Therapy depends on the age of the patient, gender, disease being treated, severity of disease, target organs, and radionuclide tracer, what we are using for the specific target organ. All the patients are dealt in a multidisciplinary team. All the patients are referred from outside, goes into the tertiary center. We discuss with all our friends sitting there, make a decision, and then approach to the patient in a very specific manner. We'll talk about thyroid. We can't get away because this was the first, basically, theranostic treatment which initiated long time ago. Some of you attended the ENM last year. There was a big discussion about the guidelines. We have been fighting about it, and especially the Europeans in one group and the Americans on the others. And we don't liaise and we don't follow the ATA guidelines. Because ATA guidelines, I don't follow Europeans. We have got a very specific means of basically treating patients, categorizing them, even though if you categorize them as the low, intermediate, high risk, but still there is a variation. So even in the low risk, where the only exception in patient with unifocal papillary thyroid cancer, less than 1 centimeter in diameter, who lacks evidence of metastases, thyroid capsule invasion, history of radiation exposure, unfavorable histology, tall cell, columnar cell, and diffuse sclerosing type. But the biology changes from the population to population, so you don't see what you see in US or in UK or in Pakistan. Is quite variable. So you need to adapt according to your where you are living, where you reside. So recommendations for ATA is RA remnant ablation is not routinely recommended after thyroidectomy. RAI adjuvant therapy should be considered after total thyroidectomy in ATA intermediate and high risk level, which everybody agrees to. The goal of iodine 131 therapy should be characterized as a remnant ablation, adjuvant therapy, or treatment of known disease using standardized definition. Adjuvant treatment should be based on multidisciplinary management recommendation. This is very important. Conclusion, unfortunately, there is no robust evidence in providing recommendation for radioiodine treatment. The medical societies together, ATA, ETA, ENM, and SNM should be committed to produce joint guidelines for the benefit of patients. At present, they are working together. Hopefully, they will come with something formulative. The next, iodine MIBG. The challenge is to improve the effectiveness of the targeted radionuclide therapy with MIBG. Possible solution using higher dose combined with radiosensitizers. We did a study where we radiosensitize the tumor. When they come to the therapy, we give them chemotherapy. And after 4 hours, we give them MIBG. And the results are quite good. The response rates were about 20 to 50%. So this was our first pilot patient, a child who comes in, we sensitize them, and then after that, a very good response with very faint uptick in the vertex. Another distribution, there is different basically modalities available, and you see the spectrum of uptake. On the left, you have FDG and MIBG. So look at the difference in presentation of the disease. So quite extensive on FDG, but not very significant on MIBG. So another case, again, patient had 1200 MCI and almost complete response after 1 year. Again, different presentation, between dotatate and MIBG. Look at the spread of the disease and on MIBG. So you need to do an appropriate test. In UCL, all the patients that comes for MIBG, we do FDG, we do gallium, and we do a triple investigation. And then we have got a mix and match if we want to switch on for therapy, lutetium or MIBG, because of the renal or bone marrow suppression, we can switch. Heterogeneity, we already seen between the 3 images, basically different presentation because of the heterogeneity. And this was our first case study of 124. It was a research project, and look at the image, spatial resolution better than MIBG, and the spread of the disease, the sensitivity of picking up the disease on 124. This is one of my recent patients who was treated in India, pheochromocytoma, had multiple MIBG therapies, and I gave him 2 doses very recently, and almost complete. His blood pressure is gone, he's not on any medication, he's not diabetic, and now basically he is back to work. Neuroendocrine tumor, probably I've got so many, so basically you know all this, basically looking at the modalities used differently depending on the high grade and low grade. High expression is basically you can see on carcinoid, gastronoma, pheochromocytoma, neuroblastoma, medullary thyroid, pituitary, meningioma, Merkel cell, and small cell lung cancer. I will go quick, and then I can probably, some of the questions which you have been asking, I may be able to answer your questions. This is important. So there were some questions, it overlaps with the PSMA as well as neuroendocrine. So you have grade G1, G2, G3 with the Ki index less than 3 and more than 20% with mitotic count corresponding to the Ki index. So now people are moving towards what combination treatment can we give. So if it is G1, you know exactly, even G2, you know exactly that you can treat with DOTA. But if it is G3, where do you do a PET, it's very avid disease, then what do? The patient goes on immunotherapy or chemotherapy. But there is a segment where they overlap in between, so you can try both. I have tried both, where patients who have come to me, young patients who are not avid on gallium and not avid on PET, but they have responded to the treatment because their diarrhea disappeared, flushing disappeared, blood pressure disappeared, though had symptomatic even though there was not morphological change. So it is important. So this is again high grade, do FDG, low grade, do gallium. So again, just using different modalities, you can see the distribution of the disease is variable. This is again one of my patients. There was a question asked, how long can you go and treat these patients? I've been doing this for 20 years, and I have gone beyond 10, 12 treatment. It all depends if the patient has reserve and is responding. This is one of my patients, local. He was working with me and asked for a treatment, and look at the spectrum of the response. So almost disappeared, but unfortunately then I took a break, gave him chance to recover, and then he came back after 2 years with liver metastases. We resected the liver, and then he came with new bone lesions, and I resumed again, but now he's gone into bone marrow suppression. So there are complications, but still alive. So different presentations, you need to think of what it is. This is a solitary uptake on gallium, FDG. There is again similar patients, so you need to think, you do a cross-sectional imaging, you look at it, there is a central lesion which is causing distal atelectasis, so FDG up in the atelectasis and gallium up in the carcinoid. So again, central lesion, no uptake. So again, no uptake in the gallium, nothing on the FDG. Okay, so a combination of treatments. So this is what I'm envisioning, and I have tried. So we have got Y90 with octreotide, we have got lutetium with octreotide, and we have, Siobhan has already talked about terbium. I've used terbium, but I'm getting problems because of DOH approval, and I'm not getting approval for clinical, but we have under the umbrella of research, I've done one patient, but amazing results. So with this one, we have got a combination with very good disease control rate. If you try combination, if you're not having results with the one tracer, then you can do a combination, but as long as the bone marrow results are there. NETA trial already basically talked about. So if you look at it, there is talk about progression and overall survival. So there is with the dotatate, there is improved in survival. But the thing is with the octreotide LAR, they go onto the high dose in combination with lutetium dotatate. So median survival follow-up was 8.3 years. Median overall survival was 48 months with lutetium dotatate arm versus control arm that was 36.4. So overall response was 80%, stable disease, minor response 55%, complete response was 25%, and progressive disease was 20%. Progression-free survival 2 years with partial response, and overall median was 48 months in NETA-1. So looking at it, basically looking at the gray distribution, so you can see the survival is better, 44%. And in the right, where yttrium is red and lutetium is blue, and both combination is black. So looking at the lutetium has got better overall survival with compared to even both giving Y90 and lutetium. So looking at the grading, so G1, G2, G3, G1 has better survival time. And looking at the ENET, WHO 211 grade, so G1 still better with better survival in months. Again, we talked about the combination. So this one, basically, looking at the combination, has got better survival. Okay, so let's talk about NETA-2. NETA-2, basically, I will not go into detail, but it says you can give 7.4, that is the standard dose, and then you do 4 segments of treatment. If they are responding, you continue. This is what I practice, and I can go up to as long as they are responding and they have got bone marrow reserve. The other thing is you can escalate the dose of somatostatin and then combination with the Lutera. And if you need to stop, you can break, and then you can continue after once the patient builds up their bone marrow reserve. I'll just skip that. So G1G patient relapse after initial batch of PRRT with either Dotatalk or Dotatate, multiple treatments safe and efficacious, and RACES plus persists 3 months after 4 cycles. Conclusion, low incidence of long-term effect, regulating hepatotoxicity, nephrotoxicity, and patients suggest that PRRT could be applied earlier in the disease. Patient to be treated by lutetium with high SSR expression, relatively good performance, and progression under treatment, long-term SST analogs. So prostate, we'll skip this. So we'll talk about this. Basically, radionuclide treatment with lutetium PSMA had high expression rate, low toxic effect, and reduction in pain in men with the metastatic castrate-resistant prostate cancer who have progressed after conventional treatment. I think Stephanie always basically discussed this case. This is one of my patients just now treated before I came here. Look at the response. Amazing response after one treatment with the reduction of PSA 50%. With no pain. The pain is the first symptom that disappears. This is another patient of mine. Look at the response. Amazing response with lutetium PSMA. So another vision trial is already been talked about, so I will skip. Stephanie has already talked about the comparison between the lutetium and the standard of care, looking at the endpoint, and again, there is benefit. So the vision trial talks about the response rate, disease control, and skeletal events, with combination is better compared to standard of care. So by adding lutetium to standard of care regime proved to be more effective to improve outcome in patients with a metastatic castrate-resistant prostate cancer who had failed multiple lines of treatment. So again here, we have talked about the extreme and the middle. So RX2, I can basically go and do a combination, and I can try with the lutetium PSMA as well as with the chemotherapy agents. Toxicity, myelosuppression, and salivary toxicity, nephrotoxicity, fatigue, nausea, and loss of appetite. So I'll skip that. This has already been talked about. Looking at predictor of response. So it is important what Stefano said as well. So looking at the CRP, LDH, AST, and if the patient has got less than normal, then you have got a good predictor response to treatment. Same 50% decline with progression-free survival and overall survival. Same with no visceral metastases. So the question was, can we go ahead? Yes, we can. Basically with 1 to 2 doses, median survival is 28.3. With more than 2 doses, median survival, overall survival is 99.4 weeks. So I'll skip the images. I'll go to the last one. Re-challenge therapy. This was another question. So you can always re-challenge once basically you have given a batch of treatment. You stop, let them recover, and you can start. And if the patient is responding, what I practice is basically if the patient is responding, the PSA drops to a level where they can sustain it, I will stop. And if the PSA trend starts rising, I'll bring them back and re-challenge them, and they respond very well. So conclusion, PSMA therapy is safe, improved quality of life, better overall survival and progression-free survival. Good uptake on PSMA scan therapy should be considered irrespective of FDG status. High-grade renal toxicity should not refrain from PSMA therapy. This was another question for Y90. Is still challenging. I've been doing it for now a couple of years now. These are the indications. This is our setup. You can do the whole liver, you can do bilobar, lobar, segmental. This is basically do 2 sets. Now with the, I think Boston, they are bringing the dose where you can do both MAA as well as the the calculation. So this is MAA. There was a shunt, basically gallbladder. We basically include the vessels supplying cystic artery, supplying the gallbladder. And this was abdominal wall uptake. So this was post-therapy. In conclusion, no single tracer identifies all the metastatic site in this group of patient. Combination of treatment with radiopharmaceutical targeting different cells structures may produce better results than either agent alone. Novel tracers may be helpful, especially when other imaging inconclusive. Radionuclide imaging may help guide therapeutic intervention. Radionuclide imaging may play an increasing role in evaluating effect of therapy. Thank you. I just need 2 minutes. I need an audience because I promised one of my patients I will discuss and I will get their opinion. I had 3 patients which were very difficult, young children, thyroid cancer. Okay, just quick, I will give you. She's 12 years old, total thyroidectomy, 3 nodes out of 3 positive, 1 ablation, 66 MCI, 2021 avid uptake thyroid bed, second ablation 100 MCI in 2023. TSH was 5.6 and TG was 9.1. TG-NT was 13.5. 2023 rising trend TG suppressed TG 17.5. FNA right clavicle lymph nodes negative, right L3 clavicle node 3 out of 22 after surgery. In 2022, sharp rise in TG 94. Then 2022 July, TG dropped from 108 to 17. PET negative. RAI 100 MCI was administered. Whole body midline level 6 uptake correlate with both images. TG no rise. Now in 2023, TG is creeping. She is a medical student, and I've discussed with Mayo, I've discussed myself, my team. I have got a plan, but I just need your opinion. What would you have done to this patient now? Wait, and she's very young, or treat another?
If anyone has answer, please get up and write box.
You said she's 12 years of age and a medical student?
No, this is not the medical, sorry. There was another medical.
Okay.
She's very young.
Okay, she's very young. Initially, the disease was locally advanced and there were lymph nodes, but you treated with a much smaller dose initially. So my opinion, in such a case, usually it's like we should treat such patients with more than 100 millicurie because you have to do subsequent dosing and which may not be beneficial in the due course of the disease, because as you repeatedly treat, you may need more of the iodine. So in the locally advanced disease, I think an aggressive approach from the first dose should have been done. At present, the TG is creeping. What we would prefer to do is you have planned for 100 millicurie, and if we can, first thing is that you have to make the patient more and more iodine hungry, and we usually in such cases where the response is not good, we add some lithium for a week, and that increases the residence time of the iodine inside. That I don't know what your legislations over there on the off-label uses of lithium but we do give lithium for increasing the residence time. So these are some intervention that you can enhance the dose delivered to the target and to the tumor.
I agree, and that's what I'm very aggressive with treating these patients. But in the normal oncology and endocrine team, they are very, very resistant in giving. So according to her, basically, that was the maximum we could give. I would have given 100, as I agree. And I have not given to many patients lithium, but that's good because I'd never thought of it, because I used to do it before, but I have not. So maybe we can try that. All right,
Doctor.
thank you.
Would you consider a repeat whole body? You did a neck dissection again, right, in 2021?
And still there
And
is uptake.
only 3 nodes.
There is still, I can still see
Right.
on ultrasound there is something there, and probably with the resolution, and again whole body is showing at level 6, somewhere in the supraesternal notch. So it's very difficult to go in because of 2 surgeries already done to. So the surgeons
But she's
don't want
such a young child.
I know.
Repeat doses, you got to think of other issues that may come in. So
I know, that's why, and the parents are very, very, they want an answer because it's the only child.
Localizing the area where the uptake is
It's just, I can see on ultrasound there is a soft tissue there.
There's a
But
lymph node or something.
It's just a tissue which is not basically, it doesn't conform to lymph node, it doesn't, it's
So
not a muscle, but
So
it's there.
SPECT CT can help you into exactly
Yeah, no,
localizing, and surgical resection can be.
No, they can't go in because they have already operated twice, and it's just around the aortic arch.
Okay.
Could it be thymus?
No.
If the patient is very young, so they may develop increase in
No,
size of thymus.
It's not thymus. It's a small nodule.
So mediastinoscopy or local camera-based surgery can be helpful in this patient.
No, we know there is disease there, but what is the option? They don't want to go in. Should we treat? Should we wait?
I think we
So-
are running short
Yeah.
of time.
So anyway, thank you. We'll
We will
try.
discuss this later on.